Welcome back to another episode of Open Globe Talk. This is your co-host, Rizal Nathani, and I'm joined with Dr. Buchan and my other co-host, Zoha Mian, who's a rising fourth year, taking a gap year to do her master's at the London School of Hygiene and Tropical Medicine. And we're so excited to be doing this multi-person panel where we're getting a take on not only Dr. Buchan, but also Zoha, who's currently a student attending this wonderful program. So let's get started, Zoha.
Yeah, so just a little bit of background about our guest. Dr. John Buchan works part-time as an ophthalmologist in Leeds in the United Kingdom and is a part-time assistant professor at the International Center for Eye Health at the London School of Hygiene and Tropical Medicine. He's also the program director for the Masters in Public Eye Care at the school. So I think we'll just get right into it and start with our first question. So what motivated you to specialize in ophthalmology and pursue a career in public eye care?
Well, I as a junior doctor, I was working in ER, in emergency departments in the north of England, and I think I'd become increasingly aware that we're all living longer and longer, and my own grandparents had lived into their 90s, and there were some elements of that you thought, we're living long enough. I don't think we all need to be living longer and longer, but I do think we need to be living better and better. For me, I really felt that with ophthalmology, there was the way to improve quality of life without necessarily making life longer. And I think really filling our years with life rather than filling our life with years is probably what motivated me. As far as public health aspects of eye care go, so I got into ophthalmology, but I realized I was treating the individual patient in front of me. And as with many of my colleagues, we were obsessing about how to care for the individual that's walked through the door. But what we were less good at is lifting our eyes up away from the person in front of us to the whole community and thinking, well, who isn't sitting in front of me? Where are the patients who have not yet come to the service and really ought to be at our service? Where are the patients who are currently blind from cataract or who are going slowly blind with glaucoma or diabetic retinopathy, who are at home either unaware that they need help or unable to access that help? And really, I felt that I could do more good taking a public health approach than by becoming obsessed with the patient in front of me, because I have plenty of very hardworking and intelligent colleagues who were happy to obsess about the patient in front of them. So I've left them to do that, and I've now tried my best to get involved with public health for eye care. Can I just say, I'm not disrespecting my colleagues, and if you're one of those ophthalmologists who's really caring for people in front of you, I will be glad to be your patient when I develop some sort of eye problem. So we need everything, and I think that's the thing, is that in a sort of equality, diversity, inclusion agenda, we just need everyone. But probably we could do with more of us thinking about the public health approach to eye care than currently, because it's not very much pushed in curricula in medical schools, either in Europe or in North America, to my knowledge. So I think probably public health approach to eye care has more, we haven't gone there yet as much as we could have.
Agreed. Dr. Buchan, you've spoken a little bit about public health. Can you kind of give an overview of what the master's program in public eye care at the London School of Hygiene and Tropical Medicine is like, and what is the significance of it in the grand scheme of global health?
Great. So our MSc in Public Health for Eye Care, as with most MSc in European centres, it's run over 1 year, but it's pretty intensive. And it was set up about 30 years ago by colleagues who had that same sort of revelation that we needed to deal with populations, not just patients. And so they started it with a very international feel. It was designed for people working in low income countries. because in those settings, particularly, you can't rely on patients coming to the doctors because people have a different view of healthcare, often maybe slightly more fatalistic, and they also don't have the financial means to access healthcare. So unless we do something for those people, then many people either go blind needlessly or remain blind entirely unnecessarily. And so I think it was when people started looking at the epidemiology and realizing there are countries on earth where there's 1% of the population is blind, 1 in 100 people, and 80 to 85% of those people are totally unnecessarily blind, that they could have either their blindness cured or could have been prevented going blind. There's a sort of minimum threshold of blindness that we can't avoid, and it's then our job then to think, well, we need to then do what we can to make rehabilitation possible and make sure that, despite visual impairment or blindness, that those lives are still full and productive. But that, again, is another aspect of public health, I would say, is sort of tertiary prevention, preventing the impairment that comes with vision loss.
Mhm. Yeah, and I know you mentioned that originally this was designed for individuals that were coming from low middle income countries. So I'm wondering, when those individuals come here, do you feel like there are any unique opportunities or perspectives that arise from being at such a prominent and historical institution like the London School? And additionally, how do you feel like the country's past with respect to colonialism, how do you feel like that affects these perspectives?
Yeah, I mean, it's a huge subject for us really in the UK, but also in the London School. In the past, people's approach to healthcare in general was very paternalistic, very much about, we know best and we'll help you to realize it. I think it's a journey we're still on. I don't think we're there yet. I think, you can see it in healthcare generally that when research is done, it's generally done on males, not females. It's generally done in high income countries, not low income countries. So to what extent are the findings of the research that's done in this world relevant to people of different ethnicities with different nutritional backgrounds, different genetic backgrounds? These are questions that aren't answered because running medical trials is very expensive. So we have to extrapolate then the results of trials done on males in high income settings to the rest of the planet's population. And that's not always a valid, there's a lot of assumptions in there that aren't entirely valid. So it's a tricky issue, but I think the main thing is for us to realize that there are issues there, and almost it's a bit like learning surgery. You start off and you're clumsy and you don't know what you're doing, but eventually you kind of realize, oh, I can't do this, but if I practice, I can get better at it. And I think with the decolonialization of the global healthcare and the way we approach many problems, really, and imposing cultural worldviews on other countries, then that's something that we are, I think, slowly getting better at. So I definitely don't think we're there yet at all. And I think the more conscious we remain of it, that there is a problem, that then we, at least that's the first step to dealing with
Yeah.
the problem.
And do you feel like the school being in London specifically, do you think that adds anything, takes away anything? I know
Yeah.
people always ask me why London specifically, and I have my own answer, but I'm wondering if you have your answer.
Well, we have discussed that, in fact, but with the global situation in the world, if you move the course to Mumbai in India or to Nairobi in Kenya or any large city anywhere, actually the rents don't get that much cheaper. The air quality doesn't get better. It's like you're living in a big urban center, and it's the world is expensive. London is an expensive place to bring people to. It has certain advantages, though, I would say, in that it is a very international city. So you might go to a city like Paris, and you'll find certain communities from, say, Algeria or from Mali or Niger, but you won't necessarily find the whole world there in the way that you do in London. So if you want to shop in a Somalian shop, you can do. If you want to eat in an Ethiopian restaurant, you're welcome. You want to it literally, there's communities from all around the world in London, and I do feel it has that as an advantage. The weather's not such an advantage, perhaps, but the
Yeah,
yeah. Yeah, I'd be very interested, Zoa, in what your answers are. But I feel like London's central enough, and it does just about work. But we had looked at relocating to a low income country. If we're going to learn about that, we would be easier to
right.
get lecturers from low income settings. Um, but we felt like it was still working for us to be in London.
Very interesting.
Yeah, on the topic of the program itself, I noticed that, a lot of governments have an issue kind of incorporating policies for eye care. A lot of ministries in low middle income countries don't even collect surveys for eye health on a regular basis. And you'll see a lot of data that is missing just because it's difficult to do these types of surveys in the first place. So in regards to the master's itself, what does it prepare its students for, and what sort of careers are they looking
Mm.
forward to when they come out of the program?
Yeah, absolutely. So we're very focused on what people are going to be able to do afterwards that they weren't doing before with the MSc, because we're taking often busy people, particularly those who come from low and middle income countries. They're often at a slightly more senior position in life. They tend to be, say, a decade into their career, usually as ophthalmologists, sometimes as optometrists, and so we're taking them out to London, and we therefore need to give a lot of added value to when they return to the roles they were in. People tend to fall into three groups. Some people really take on research, and therefore they become part of the solution to the information gap that's there. So finding treatments for diseases that are more prevalent in different settings, and treatments that are appropriate and are acceptable to local communities. So some people come out, and we train everyone to be a researcher. I aim as the program director to get every one of our students to do a research project that is of publishable quality in an international peer-reviewed journal. And we're over a quarter of our students publish in international peer-reviewed journals their research that they do, but we're aiming to get that to over half. And that, just because a piece of research doesn't get published doesn't mean it wasn't of good quality, but sometimes it goes into a report to a Ministry of Health, for instance. So quite a few of our students will do research, say a situation analysis and evaluation of, say, childhood blindness prevention in their own setting. Now that's going to be difficult to publish in a peer-reviewed journal. The readers of JAMA ophthalmology aren't interested in that, but it is very interesting to the Ministry of Health then for their healthcare planning. So, and that brings me to the second role that we have, which is national public health planning. So there's the researcher group who then go on and continue doing research, and we have about 15% of our students who graduate go on to do a PhD in a lower middle income country setting. So that's a really positive statistic for us, and we really do encourage ongoing research. But if you're not doing that, some people go into a public health type role or healthcare planning. So if you look at lots of the international non-governmental organizations, such as CBM or Sight Savers or Fred Hollows Foundation or Helen Keller or other charities that work with blindness prevention around the world, they very often have people who've graduated from our course either leading them or advising them, but also not just in the non-governmental sector, but in the governmental sector. We have lots of graduates who are in senior positions. So in ministries of health, such as in Kenya, Dr. Michael Gichangi, he did a course. He's now very senior in the Kenyan Ministry of Health, leading their efforts to promote eye health around the country, and that's really encouraging. Similarly, in Nigeria, Dr. Terry, she's the head of blindness prevention in the Federal Ministry of Health in Nigeria. And just to name a couple of examples that leap to mind. So our graduates go on to run programs, design programs, monitor programs, and evaluate them for the governments or for non-governmental organizations, as well as doing the research that builds it. And some, I was going to say just become teaching hospital consultants, but the word just is not appropriate, obviously. Some people become consultant ophthalmologists or senior optometrists, either in a university setting or in a clinical setting, but with a public health approach to what they're doing. So they're in a hospital delivering secondary or tertiary level eye care, but they're also running outreach programs from their hospital, running a sort of hub and spoke. They might send out uh, buses to villages and have village health screeners looking for eye disease and bringing people who would never come of their own accord. But because those senior ophthalmologists or optometrists have been on our course, they understand that there are blind people sitting who are never going to come. So they go and find them. And that really is those kind of three groups of people is who we're training and mostly who comes out. Every year we do have people from high income countries. So if you're listening to this and you're thinking, well, that's not me, I'm in the US or in the UK, and I'm planning to stay there, but there's still a lot that we can do, either in supportive roles for research or in education and training and academia that does support the efforts to deal with unnecessary blindness and prevention around the world.
And I imagine that you've taught so many trainees from all around the world that are from so many different backgrounds. I'm curious if there's been any, specific trainee or a group of trainees, someone's story that you really think has impacted you the most, like either from their background or what they ended up doing after the master's, or a mix of both. I'm just curious to see if there's any kind of experience like that you've had.
Yeah. Yeah, so when you think of people who passed through the course, I was looking. In fact, we had a celebration of the course after 30 years, and thinking and picking people from the past who had done the course, who'd really gone on to great things. So there's Professor Hannah Fall from Nigeria, who became the president of the International Agency for the Prevention of Blindness. There are people who've gone on to work with WHO in their prevention of blindness team there. But actually, it was in one of those photos with one of these high-flying international leader type people, and I saw a guy's name, Samuel Coker, and I was like, I bet nobody has ever heard of that guy, but I had heard of him because I went to work in Sierra Leone for 4 years. Sierra Leone's a small country in West Africa next to Liberia, which you may be more familiar with, but it's very similar to Liberia in many ways. And in that country, in a small rural hospital, a couple of hours drive from the capital city, worked this Samuel Coker, who had for 30 years been running outreach services. And he had been taking a minibus team every week, 3 days a week, to different villages. They'd been screening local people for eye disease, finding people who were blind with cataract, taking them back for surgery, which he was also doing. And he was running this community ophthalmology in a difficult, very poor setting, one of the poorest countries in the world with really limited resources to put into healthcare, but with many great people working very hard to bring hope to those people. And it actually, because I had just seen this guy just once in Sierra Leone, and he was coming towards the end of his career, but no one's ever going to write a story about this guy at all. He's just never going to be famous, because what has he done? He's sat in a small hospital with very little electricity for 30 years, but he's responsible for thousands of people seeing again who would have been otherwise hopelessly blind from cataract. So, I'll share that story.
Yeah, highlighting silent heroes.
Yeah, absolutely.
So, Dr. Buchan, can you share some critical global health challenges in eye health and vision care in these low resource settings? We've been talking about, we've been touching upon these other things about surveys, Ministry of Health, but what exactly are the challenges that are in low middle income countries related to public eye health?
The difficulty of getting accurate information from surveys is to some extent a constraint, but many years ago in India, a team led by a Dutch eye researcher called Hans Limburg developed this rapid assessment type methodology, which has then grown and is now being popularized around the world. So, whereas in the past you might have taken a whole list of the whole population and gone and examined a few thousand people, using this rapid assessment methodology, we've been able to really limit the amount of effort that's necessary to come up with pretty accurate estimates of how many people are blind, from what diseases are they blind, where do they live, how is that distributed, which makes it much easier for ministries to plan. And if they haven't been able to do one of these RAB, which is an acronym standing for Rapid Assessment of Avoidable Blindness, if you haven't had a RAB in your own country, you can look to another country with a similar demographic and sort of pinch their results, and that gives you a fair idea of what's going on. But perhaps I can exemplify the challenges more by saying, even if you take a fairly, say, like a really well organized and hard working functioning country like India, so it's a middle income country, and many of the richest people on earth live and come from India, and yet it still is home to a large percentage of the poorest people on earth as well, because it's about how do we redistribute access to care. And there's inspirational stories from there. I'm sure your listenership will be very familiar with hearing about Aravind Eye Care Services in Tamil Nadu, and the inspirational story of those who set that up. So stop me if you've heard it all before. But the solutions they have found there, which mean that some of the richer people can pay to subsidize the services for the poor, so that more than half of the, say, cataract operations they deliver are done completely free of charge to the patients. That kind of story is possible in a country where you have some rich people like India. The challenge, I think, for us as a global community is not a middle-income country like India, which really has its own solutions. I don't think India is going to. No one can stop them from improving because they have the will, they have the skills, they have everything. All the answers are there within their own setting. So I don't think necessarily that a country like India needs our help, but I think there are countries, and I mentioned Sierra Leone, great people there, but it's very difficult when you have limited financial resources. So there's not limited manufacturing. How do you get foreign currency in order to buy in equipment? How do you start manufacturing when there isn't manufacturing in your country? You can't make surgical instruments. You have to buy them from abroad. You can't make medicines very easily because you have to buy the pharmaceutical agents from abroad. I think it's very difficult for a country to get started when you're far behind, because basically it's just cheaper and easier to make drugs and make instruments in Pakistan or India and then import them. So a lot of surgical instruments that we use in the UK or when you're in Africa, you may buy them from Pakistan because you can't start up your own instrument manufacturing facility. So I think the challenge is going to be, how do we make sure that this low-income countries don't get left behind? I've heard them referred to as the bottom billion. If there's 8 billion people on Earth, there's 1 billion people who, people used to talk about the developing world. I don't know if that's still a term that's used, but there is a cross-section of this world that isn't developing at all. And it could be this bottom billion people in the world are often living a life not dissimilar to how they would have lived for hundreds or even thousands of years, because it's just hard to get your first foot on that ladder to develop and start manufacturing and start making stuff, start developing foreign income, exporting things. And I think probably the world needs to concentrate more on low-income countries and I think stop aggregating low and middle-income countries. For me, that's an unhelpful phrase, low and middle-income countries.
And I know you talked about how so many of these students that have come in the program have eventually, if the paper doesn't get submitted for publication, it might go to influence a ministry's health plan in the future. And I know we've talked a little bit about this recently in class, but I imagine advocacy and policy have a huge role in all of this. So I'm curious, in what are some of the ways that advocacy and policy, how have they impacted your own career as a global eye health provider and researcher, if at all?
Yeah, I'm always. I remember at medical school, they were talking to us about, say you're a paramedic, you arrive in an ambulance at the scene of a massive car crash. There's several vehicles, there's bodies everywhere, and there's 2 or 3 people who are crying, they're screaming out in pain. How do you prioritize who to look after? the person crying and screaming out in pain is absolutely fine. Okay. They've got lungs full of air. They've got plenty of life still in them. You can ignore anyone who's shouting loudly to start with. And you need to go to those who are silent, and those who are lying there slowly bleeding out on the floor, or who can't breathe because they're, being strangled by their seatbelt, hanging upside down in a vehicle, or something like that. And it's those who are not shouting loudly that need the most help, I would suggest, in many situations. And this, I think, is one of those. So advocacy is really about finding those who are least able to speak for themselves. So, for instance, if you think about even your own eye clinics in the US, or certainly in the UK, we care a lot about the patients coming in until the point at which we can't help them anymore. Mm-hmm. So if you've got glaucoma, the day that you've lost your last spot on the visual field chart, we've got nothing left to save. We can't do anything. You're done with us. So we kind of let you go at that point. And in many settings, I think that is the case, is that people give up on people they can't help, because we're doctors, we like helping people, and people we can't help are. So I think there's more that could be done, and I'm impressed with organizations like CBM. Christoffel Blinden Mission is a German-based charity which I worked with for 4 years in Sierra Leone, and they had over the decades made a great deal of effort to try and not forget about people beyond the point at which they've lost their vision. And I think that's something that needs not to be forgotten, particularly for children. Your life isn't over just because you're born with an unrepairable visual impairment. You've got a whole life ahead of you, and it's up, the rest of us need to do everything we can to make sure we're empowering people to live those full lives that they really can live. So, so I think advocacy for those who need it, who can't advocate for themselves, is really where we need to go. And examples of that probably would be something like retinopathy of prematurity, which Professor Gilbert from the London School did a lot of work with in middle income countries, as babies, premature babies, were surviving longer and longer. So say in South America or in India, these babies are surviving from a very young age, but not quite getting the ophthalmic care necessary to prevent them getting retinopathy of prematurity. And so a lot of work's been done to make sure that ROP screening is done in every setting where it can. And in the London School, one thing we do is set up networks. So we have an ROP network. There's a diabetic retinopathy network. There's a glaucoma network. There's a retinoblastoma network. And with these networks, we try and link up anyone who's interested from different countries, so that a country that's done really well with ROP screening, that's got it set up and is institutionalized, and they've really nailed it, so that they've minimized blindness from ROP in their setting, they can speak to others who are far behind that curve and say, yeah, these are the steps to get this one sorted. And part of that is advocacy, because it needs funding. And obviously the parents of those premature babies are unlikely to be able to fund that themselves.
Yeah. One thing, we've been talking about is advocacy, and a lot of people don't know how to navigate that, right? And one thing that I've noticed with a lot of different organization leads is that they often gravitate to programs that are already set up in countries. And you then have this concentration of specialists in one part of a country, but then the neighboring country, for example, Sierra Leone, is neglected because there isn't that infrastructure as much as, let's say, Ghana or Kenya.
Yeah,
and so how do you find these people who are underserved and silent sufferers, and then two, trying to advocate for them? What does that even mean?
Yeah, so you're absolutely right. If you want to run a successful program, and say you're a charity, you want to fund something that you can feed back to your donors, look, we've done a successful job here. You don't go to a low income setting, because things won't work. The roads will be difficult. Your vehicle will break down. There'll be no electricity when you turn up to do your operating room. There'll be so many difficulties, and you'll end up with quite a lot of challenges, and it just won't deliver the success that you were hoping to report with the money that you gave. And in some ways, we have to just man up, if that's not a sorry, terrible phrase to use, and say, okay, things won't go well, but we're still going to do this, and we're going to keep doing it until they go better. And I think the desire for quick wins is this, like the political cycle. Everything has to be done in 4 years, or else it's, so what government can set up a 10-year project? Because they may not be in power in 10 years' time. So they want something that makes them look good within the next 4 years. So there's another election, so they can win that election, or whatever it could be 5 years, 3 years in different countries. But basically, the political cycle marries us to short-term gains. And some things are not short-term gains. There are no easy wins, I don't think, in development. As we can see, how much charity money has been spent over how many decades, and how far has it got us in certain settings? You can go to places and realize we're not really progressing very well. And so I think we slightly need to be able to have a mature conversation and say we're in for the long haul, and say that to donors as well, is that actually you may not get back a photograph of a smiling child who can see again or something like that, which is what you want. But instead, we're going to put this money into something much more long-term and strategic. But that is hard to do, I think, from a non-governmental point of view. So governments need to be able to wear that lack of short-term success as well, and bilateral donors. So I think probably a slightly longer view on what we want our international money to do and our international efforts to do. And it's like, when I went to Sierra Leone for 4 years, I'd been there for 2 years, and I tried to institute things within our hospital, like stock take mechanisms. We'd got contracts for the staff who hadn't had job contracts before, and we were buying drugs before they ran out instead of waiting till they ran out and then going to try and buy some. So that kind of stuff. Very simple things. But I realized after I'd been there about 2 years that if I left the hospital at that point, everything that we were doing would stop, because no one else really owned it. It was kind of like me pushing this ball up a hill. And if I stop pushing, the ball's going to roll back down to the bottom where it started. And I needed to hand the ball over to everyone else. And so actually, by the end of the 4 years that I was there, I started turning up to work late. I stopped checking on things. And there were problems, sure. But I stopped after about 3 years. I really started working less hard and just deliberately letting things go wrong.
Yeah.
I remember when we did an outreach trip, we were going to drive for 4 hours, and I didn't check all the equipment myself. Previously, there's a team of like 10 of us going, and previously I'd got everyone else to load the vehicle with a checklist, but I always checked everything myself, because it's 4 hours of very bumpy roads. But the last couple of trips I didn't check, and the second last trip we drove for 4 hours and we arrived without any knives, any keratomes. We didn't, you can't do any surgery without the keratomes. Who packed the keratomes? It's ticked on the checklist, but it's not in the box. And I knew, in fact, without being, I don't want anyone to hear this as patronizing or unkind. I knew that we weren't good at checklists, but I knew we needed to take the pain. So we all got there. Everyone was very annoyed and disappointed, but I wasn't. Because without failure, you can't have success. And so someone had to get on a motorbike and drive back for 4 hours. And then, so it was the next day, we were all day delayed and everyone stayed away an extra day. And, but yeah, that's just a kind of small example of how we 2 years was too short. So we need to, if someone wants to go and help in another setting, they want to go for 3 weeks, that's great. But it's really what we need is long-term commitment and long-term relationship to build structures that protect us from ourselves and allow us to be more than we are.
Mm-hmm. Yeah, I agree with you, trying to make people learn through mistakes, because if you were doing the checklist yourself, then, they'd get used to depending on you, which isn't building on sustainability.
Yeah, and the day I left, the next outreach would have gone badly, and then maybe they'd have given up. So, but the fact that I was still there, and we had the problem, we overcame the problem, we kept going. The next checklist I didn't check, and we got everything. Everything was there, and we did the outreach, we did the surgeries, and it was great. And I felt like we've arrived,
And
because I'm not pushing.
Given all of these challenges, that it takes to, really help certain areas, especially as you mentioned, low income countries, to navigate all these problems while you're actively trying to solve a problem such as eliminating blindness, which is not a small problem by any means. There are obviously a lot of people, including myself, that have that strong desire and have that motivation to want to go out and do this work. But obviously there are all these challenges to be met and hurdles to be overcome. So, what advice would you give to people like me or other individuals that are listening, to aspiring professionals who are interested on this path and want to, help tackle these huge world challenges? What advice would you have for them, if any at all?
Um, yeah, in some ways, we need to decide what we've got to give. Um, some people have more to give than others, and I felt like I didn't know what I had to give when I set off, but I felt like I didn't want to live in a world where we didn't at least try and help those. It's not right that people are sitting unnecessarily blind in many villages, in other places where it just didn't feel like that was a world I wanted to be part of. So, I definitely knew and felt called to make a difference there. So, um, and there's other people like the hospital I went to work with had been set up by a legendary American called Dr. Lowell Guess, who'd spent 25 years living in West Africa himself with his wife and 6 children. And we can't all be legends. And I just felt like I'm not a legend, but I'm going to do what I can and give what I can. And I think that's what all of us need to do. Um, and, for some of it will be giving money, but if you can give years of your life, I mean, I don't know anyone who regrets going to work in a difficult setting for several years who doesn't regret it. I know some people have gone for short periods of time, like go for 3 months, and then maybe regret that they didn't do more, actually. But I don't know anyone who's worked for more than a few years who doesn't feel like they were the best years of their life, really. And because you're making a difference, every week we sent our minibus out with a couple of nurses. They would screen people in villages. They'd come back with a minibus with 15 seats and 20 people in it, who were all blind preoperatively, and they were getting our median pre-op vision unaided was 20/60, so which is pretty good, given that you're preoperatively hand movements or perception of light. So to do that for more than 1,000 people a year really was very life-giving, and to train others to be able to continue doing that after I left. And in fact, that was probably one of the best weeks of my life. Was I went back a year after I'd left earlier, and I went back to the hospital just to visit, and I went to the theatre to check the logbook, and I could see they had done more operations in the year after I left than the year before I left, because the systems we'd put in place had continued working. The outreaches with the minibus were still happening. The patients were coming in larger numbers as the reputation grew, and that was a great moment to see that. I wasn't a necessary part of this machine at all. I'd given what I had to give, which was training others to do what was necessary, and the others were doing it, and doing it in great, with at a very high level. It was really heartening.
Yeah, ideally, you don't want to be a necessary part. You want to
Mm.
do what you can and, make sure that they're sustainable and hopefully, it continues on even when you're gone.
Yeah, absolutely.
I think I learned from Zoa that you guys, the master's candidates, go over to a foreign country to work, and this relates to their paper. And I was just kind of curious how that works, because I think we touched upon kind of setting up how the expeditions look like, but I'm also curious, how does that translate to the students who've spent almost close to a year learning about the public health principles?
Yeah. Well, historically, our master's program, as I say, was set up for people from low middle income countries. And in the last 15 years, 80% of our students have come from low or middle income countries. Now, we've since the pandemic, we've had a reduction in the amount of scholarship money we've been able to find to bring people. We still have half a dozen people from low and middle income countries who are supported by scholarship donations, and that's great. But we also have a lot of people from higher income settings who also want to be part of global eye health and from a public health perspective. So the people who are from low income country settings normally go back to the setting they're from to do their research project. But those who are from Europe or North America, because we have International Centre for Eye Health is really a network of researchers around the world. It's not just a group of people in London. London is the sort of focus of it, but we have full-time employees in many countries, in Tanzania, India, Nigeria, Kenya. There's people in a lot of different countries working with the International Centre for Eye Health, and therefore we're able to find partners for master's students who then can go and contribute their research efforts to ongoing long-term programs in other settings. So it's not like you're kind of parachuting in, getting a bunch of data and jumping on a plane out of there to go and write up your paper, which is something which is a bit frowned upon. Rich people getting papers out of low and poorer people's data isn't very decolonized. So we avoid that. What we want to partner with local people, and it often means that you for the research process, you partner with locals. You can get translators to work with you, and then the student often, if they're doing most of the work, would be the first author on the paper, but they would tend to have 2 or 3 or 4 local partners who've helped them with that research, who are also authors on the paper. And often those people are long-term researchers within those settings themselves. So it's a model that's working fine. And not to forget that there are people in high-income country who need our help as well. So in the US, I'm sure your listeners will be well aware that although you have the best healthcare on earth, not everyone's accessing that. So, there are definitely public health questions to be answered. And we've had recent students from the US who have looked at exactly those sorts of questions, producing very powerful research showing where the disparities are and, possibly suggesting some means how they could be addressed. So, and it's the same for the UK and other European countries. So, yeah.
This has all been really great. And honestly, I was just kind of like reflecting on my own experience so far. I've only been here for a week, but I already feel like my whole worldview has changed on the perspective of eye health care. And I remember in our meeting, I kind of didn't really know where I wanted to go or what I wanted to do exactly. I had some ideas, but I do remember saying to you that I do want to go somewhere and develop a long-term relationship with them one way or another. So I'm glad to hear you echoing that same mindset. So I guess the last question to end all of this is, what really is your vision for the future of global eye health?
Yeah, I mean, it's the International Centre for Eye Health is one of those organizations that hopes to do itself out of a job. We would love there to be university public health training in many countries, so that you are lectured by people from that setting, and the students can go and stay within their own setting, don't have to drag people to London. So certainly that is a future that I see as one that is necessary, really, is to devolve the academic aspects of the research and the education that currently is on offer at the International Centre for Eye Health is they're then delivered elsewhere by national people in their own universities. The journey to that point, though, the trouble is that many of the answers to these questions are macroeconomic. We can do what we can, but what we can't do is change commodity prices or even currency prices. So anyone who's following global currency will know the naira in Nigeria has lost a third of its value in the last 6 months. And that's a huge impact on the people there, because everything that you were sourcing from abroad suddenly becomes 50% more expensive. So those kind of forces are beyond our influence. However, what we can influence is, I suppose, a problem-solving approach so that people are empowered to say, okay, there are difficulties here, but ultimately there has to be a solution. It cannot be correct that 80% of the world's blindness is avoidable or preventable, because blindness is too unappealing for most of us. Yeah, those of us who can see well would not want to give that up. And we therefore feel it's incumbent upon us who are in places where we have some influence and are able to help, that we need to do that. I feel it's that the future of global eye health, then, if to really answer your question, is probably in the hands of economic forces that we can't influence. So we can only influence what we can influence, and it's therefore knowing what you can do and doing what's given to you to do is the essential thing, really. So, yeah. Even just, participating, listening to this podcast, participating in these conversations, it keeps it on the agenda. It means that the whole world knows that we are not just ignoring our responsibilities, and that there is hope. And the more conversations we have, the more this is talked about, the more those solutions will come out from unexpected places in unexpected ways, and we will move to a better place, I'm sure.
Yeah, I agree. Dr. Buchan, I think one of the things we don't realize is how important economics can be in the way that low middle income can be affected, and more so low income countries, because these are perhaps the bottom billion, as we mentioned. And so I think, we've learned a great deal from the session, and thank you, Zoha, for connecting us with Dr. Buchan. I think we've had a wonderful conversation with you, and kind of picking your brains about how your experience has been kind of leading this project, as well as, how the master's program operates, not just in London, but internationally.
Yeah.
Okay. Well, Rizal, thank you so much. And Zoa, thank you for the invitation to join you for this podcast, and all the best with future editions.
Yeah. Thank you. Thank you. All right.